We need people in healthcare. We need people like the two of you who are coaching people and helping people live their best quality of life, because we're otherwise kind of headed for disaster, I think. I mean, I cannot tell you how many young people that I get asked to fill out disability paperwork for. This is not good, because it's also, we get so much fulfillment from being able to do work. And for me, going from being not able to work to being able to work and to serve other people and finding my purpose it gave me my life back. And that's what I want to do for other people. I want to be able to give them their life back. And I'm hoping that I can also do it on a bigger scale. And that's why I do the podcast and other free things, because I know not everybody can afford to come see me one-on-one. So I do offer a lot of free resources. And the goal is to have more things like classes and giving people the tools that they need in whatever the best, most efficient model is.
Welcome to the Wealth Podcast. I'm Katie Goss.
And I'm Andrew Dettelbach.
On today's episode, we have a very special guest. This is our first guest on the podcast, Dr. Linda Bluestein, also known on social media as Hypermobility, MD. Dr. Bluestein is a board-certified anesthesiologist, integrative pain medicine physician, and former ballet dancer. She specializes in treating dancers and other athletes at increased risk of hypermobility disorders. She founded and co-hosts the podcast Bendy Bodies with the Hypermobility MD, and is a former co-host of the podcast Hypermobility Happy Hour. Dr. Bluestein contributed 2 chapters for the book Disjointed, Navigating the Diagnosis and Management of Hypermobile Ehlers Danlos Syndrome and Hypermobility Spectrum Disorders. Through her private practice, Hypermobility MD, Dr. Bluestein helps countless people improve their functional capacity and quality of life. Dr. Bluestein completed her anesthesiology residency at the Mayo Graduate School of Medicine after receiving her medical degree from the University of California, Los Angeles School of Medicine, and regularly presents her work at national and international meetings. Dr. Bluestein serves as the Pain Management Committee Chair for the nonprofit EDS Research Foundation and is a member of the Allergy and Immunology Working Group for the International Consortium on EDS and HSD, the Board of Directors for the Bridge Dance Project, the Advisory Board for Doctors for Dancers, and the Resources Committee for the Dance Healthy Alliance of Canada. She is also a founding member of Dance Medica and serves as an expert for Pivot Dancer. A leading specialist in connective tissue disorders, Dr. Bluestein helped create the first online EDS CME, that's Continuing Medical Education, program with the nonprofit organization Chronic Pain Partners, for whom she also serves as a volunteer medical consultant. As an assistant professor at the Medical College of Wisconsin, Central Wisconsin, Dr. Bluestein directs the Rishi Healers Art Program. More information can be found on her website, hypermobilitymd.com.
So she's kind of a big deal. She's done a lot with her life in the aspects of helping people with hypermobility. And I think it was a really profound conversation because a lot of those things we often tease and make fun of the medical doctors in the medical community, and she's the complete opposite of the people that we often make fun of. And it was very enlightening to have a conversation where we're kind of meeting eye to eye as kind of trainers. Katie used to be a nurse. I didn't get my physical therapy license and have just been training people online, but just to see that we are both aligned in the same mission of helping people in a positive way.
And she has Ehlers Danlos Syndrome herself as well. So I think the conversation was great, going into viewing it not only from a medical doctor and medicine point of view, but also as the patient, and her even sharing her experiences of gaslighting with the roles reversed in her in the patient seat. And I think really the big takeaway is that holistic and integrative approach of really addressing all of the controllables, controlling the controllables. You can't change your diagnosis, you can't change your genetics, but you can profoundly impact the way that you feel and function.
Own it. Without further ado,
Let's
there's Dr.
go.
Linda Bluestein.
We have a very special guest here with us today, Dr. Linda Bluestein, or as you may know her on Instagram, Hypermobility MD. Thank you so much for taking the time to join us on a Sunday.
Welcome.
I'm so excited to chat with you both.
So, Dr. Bluestein has a background as an anesthesiologist, a former ballet dancer, has a certificate in performing arts medicine. She also has EDS herself and sits on a bunch of various boards and committees and really is just an amazing voice for EDS advocacy. She also has a tremendous amount of free resources that she puts out to really help people learn more about EDS, and for anyone who's either a provider or working with dancers or people who are hypermobile. So we will link all of that in the show notes so that you can access those as well. I would love to hear about your background, just kind of your story. If you want to start at the beginning and just dive in with that, that would be great.
Sure, I can start at the very beginning. As a baby, I had terrible asthma, but this was quite a while ago, and my parents would take me to the emergency room every so often, and just when I had a severe flare, take me in, and I'd get epinephrine and all of that. But it wasn't until many years later that I started having more severe allergies, gastrointestinal problems. Then I started as a later on teenager, started getting terrible joint pain and issues with my tissues in my joints to the point where I couldn't continue dancing. And I really wanted to become a professional dancer. So this was emotionally really hard on me in my late high school years. And so I kind of had a tough time with all of that, but decided I needed a plan B. And I had always been interested in science. So I decided, why not go to medical school?
So at what point did you start kind of looking into or finding out about connective tissue disorders? Were you diagnosed in high school then? No.
Oh, no, no, no.
Okay.
It was many, many years later. So I fast forward 30 years, something like that. And I was having I had a lot of problems all throughout there. Migraine headaches, joint pain, neck problems, back problems, sciatica, knee problems, etc. All kinds of, weird injuries with little to no provocation. And I kept telling my internist, something is wrong with me. I don't know what it is, but something's not right. I get injured way too easily. Terrible migraines. Terrible, terrible. Continued with the allergies, etc. And nobody had any idea what was wrong. And I ended up getting diagnosed with something called Tarlov Cyst, which is where the lining of the lining of your nerves in the spinal cord that come out of the spinal cord is enlarged, and then the pressure that happens in that area causes other nerves to be compressed. And so you can develop a whole host of symptoms related to that. And I was reading about this condition that I had that was found on my MRIs, I should say. And I came across sometimes people who have these things have a connective tissue disorder. And I went, I wonder what connective tissue disorders are, because as an anesthesiologist, I didn't really know that much about, connective tissue disorders. So I started reading, and I came across Ehlers Danlos, and I was like reading going, oh my gosh, that's me. Like so many patients, right? So many of us, that's how we figure it out. So I went to see another rheumatologist. I first saw a rheumatologist when I was a teenager. Now here I am, a mid 40-year-old adult, and I went to see a rheumatologist. And the first rheumatologist that I said, oh, no, there's nothing wrong with you. You just need to, exercise in the pool and you'll be fine. And then I saw a different rheumatologist, and he did diagnose me with hypermobile EDS. At that time, I think it was type 3, or it was definitely before 2017, before the new classification. But then he also told me there's nothing that you can do about it. And I literally have spent every single day since then trying to prove him wrong.
I understand
Can
that
relate to
a
that.
T.
It's can be a really great catalyst. We're highly motivated by similar circumstances.
In fact, your story sounds very similar to my experience. I grew up with asthma. Do you still have asthma, or did it? kind of go away.
I don't take medication for it, but I do certain times of the year and things like that are a little bit more challenging. Yeah.
Yeah. I'll experience it more with a chest cold,
Mhm.
but for
Oh,
the most
definitely.
part, it stopped after I left a very poor air quality place in Los Angeles, and it's just definitely improved from that situation on. But the pain from seemingly doing absolutely nothing since I was a very, very young kid all the way up till now. And yeah, obviously being diagnosed much later, Katie is the one that brought it to my attention. I had never really considered looking that in depth to it because I just considered it to be normal that people experience pain quite often. And she's like, well, you're very lanky and very long. She wanted me to check for Marfan's.
I
So
just thought I hadn't met him in person, only virtually, and I'm like, "You're so long, and like, your arms are so wide, and you're so bendy." And it was not that long after I was diagnosed, and I just thought, if I have this thing, you definitely I had him do some of the Baton stuff, and I was like, "You should at least bring it up with your physician," and he
yeah,
did.
so
And
the geneticist diagnosed me. So
yeah. And my situation was similar to yours in that I just a lot of the pain, the injuries with it just seemed like anything I did, I ended up getting injured. And then working as a nurse, those long shifts, it's just I always had back pain, I always had hip pain, my neck always hurt. It just seemed I felt like I couldn't keep up with everyone around me. I'm like, "How are you fine? It just doesn't bother you like that." And then after my kids, I had a very significant pelvic organ prolapse and hernias and had that repaired and the stitches didn't hold. And I just was feeling just different things coming together. And it was the same thing. I started looking something up and I was reading about the prolapse and I saw something about connective tissue disorders. And I'm like, I don't know what that really means. And started reading about EDS. And it was the same thing. I was like, wow, I have that. I have that too. I have that too. Wow. Yeah, so similar situation with diagnosis. So
Mhm.
I'd like to go back just a little bit. I'm curious, you said that you didn't learn a lot about it as an anesthesiologist or in medical school. Can you maybe touch on that a little bit? And I guess I'm also curious if they didn't really cover connective tissue disorders, did you learn about some of the comorbid conditions that can kind of go along with that, like the POTS and the mast cell and dysautonomia?
Sure. So I graduated from medical school in 1990. So that
That's
excuse
when
me.
Andrew was born.
I was just gonna say, were either of you alive yet?
I was.
yeah,
So so we didn't there was no at least not readily available, no internet. I didn't own a computer. Everything was in books. And I did learn about connective tissues, of course. I learned about connective tissue disorders to a certain extent, but the amount of information that was available was so much less. And I think a common misconception is kind of what the goal of medical school is. So the first couple of years are all basic science. So it's learning about the different types of cells and how they work in the body and histology and some neurology and pathophysiology. And it's all like basic science type stuff the first couple of years. At least it was back in my training. Now I teach at a medical school that has a compacted curriculum in 3 years. And those students do start in clinic literally in their first year. But when I went through, we didn't go start to do rotations in clinics until the third year. And we learned about things like connective tissue disorders. We definitely did cover things like Marfan's. But if you think about it, what information was actually available when I graduated
Mhm.
in 1990? And it's important to keep these things in mind because while I totally understand the frustration and Rodney Graham's line about EDS is the most neglected disorder of all of mankind, that is completely true. I completely agree with that. We also have to recognize, though, that physicians need to know about a lot of things. And nowadays, there's information so readily available. And a lot of patients, they do have the ability to do a lot of reading. They're communicating on Facebook groups, which can be really helpful. But so they can get tons of information and their doctor that they're seeing, so let's say they're seeing their PCP, their PCP needs to know how to treat infection and injuries and looking at skin cancers. And if their PCP is a family doc, then maybe they're even delivering babies and maybe they're taking care of kids and adults. And so I think because I get so frustrated when I see people say, why did my doctor say, I don't know? But I literally will read in the next thing on social media, oh my God, my doctor Googled Ehlers Danlos right in front of me. And I'm like, but you say that you want them to say, I don't know. So you should be commending them for looking it up and not just assuming that what they know is correct. And so that's where I
Yeah.
get kind of frustrated. I feel like
Hmm.
there's some double standards there because it is really hard to take care of people with chronic complex conditions in our current healthcare system.
Yep.
But these people need us people. We all need better care and we desperately need that. And it's not just us, it's anyone with any chronic condition, complex condition, multisystemic condition, because these are not, they're not a good fit for our current siloed healthcare. We have rheumatology separate from immunology, separate from gastroenterology, separate from cardiology, et cetera. And some of these conditions, like connective tissue disorders, impact multiple different systems. So it can be challenging. But what I learned about Marfans, et cetera, was pretty limited, but it was also based on what people knew at that time. Then I went into my anesthesia residency, which is 4 years. So you go to college, then you go to medical school for 4 years, then you do residency for 4 years. And during that time, you need to learn how to manage an airway and do all different types of anesthetics, and you need to learn about all the drugs. So, and you need to learn about the medical conditions that are most likely to impact your care for that patient. And you learn about positioning for all the different types of procedures. But in hindsight, yes, it would have been very important to learn. Some people are prone to dislocate their joints, and those people need to be positioned more carefully than those who don't have that problem. Not even necessarily putting like a label on it, but just as you're assessing the patient, kind of see, do they have this kind of a history? So I, I think there's a lot that could be improved, but I think it's also important to keep in mind, like, what are some realistic goals and objectives?
Yeah, I think that the card that you made for I think it's like a wallet card for
Mhm.
anesthesia, I think is so great because it's just super abbreviated and like really just the bullet point things. I'm curious when you were working as an anesthesiologist, did patients ever bring anything like that to you and how how did you respond in those situations? Or have you heard from people who have used that card and do they typically get a positive response or do they kind of get almost like an eye roll, like exasperated kind of, "I know how to do my job."
Sure. So I created those cards. I'm trying to remember when that was exactly. It doesn't really matter. But when I ironically I created those cards and I was one of the first people to get to use the card. I had surgery and I took the card with me to the hospital and I was no longer working at that hospital, but I was still working as an anesthesiologist and I no, actually I wasn't. I was not working anymore as an anesthesiologist. I had already opened my practice. That's when I had created the cards. So, but these were my colleagues that I had worked with previously. So I gave them the card and I kind of explained and it was well received. I mean, I think again, I tried to make it super succinct and
Mhm.
in their own verbiage, our shared acronyms and our shared understanding of priorities. Because part of the challenge now is healthcare systems, they want things efficient. It's all about throughput in the operating room, and every single minute is crucial. So between cases, between surgeries, you have to they have to clean the room and you have to see the next patient, and it's a pretty fast paced process. So I tried to make that as efficient as possible so that they could understand these are the things you need to be thinking about, and this is why this is important. So I have given those cards out to a lot of my patients. I did eventually decide to put them available online just so that other people could access the information as well. I do need to update that card because that was quite a few years ago so I've changed the name of my practice since then. So it's a little bit out of date, but at least most of the information is still relevant and is still there. There's a few things that I want to add to the card. And that is on my very long to-do list.
Can relate to that for sure. Yeah, we'd love to link that in the show notes too, if that's all right with you. I think it's just such a great resource. The EDS specialist who I had seen had typed up something similar, but much smaller and not the acronyms or abbreviations or anything like that for me when I was going in for surgery. And I just think it's just helpful to have something very concise like that patients can provide.
So I have a question. What's the percentage of people that might actually experience dislocations when they're under anesthesia or when they're being set up for those positions? Because I hear that and I'm like, how much of the hypermobile population does experience that severity?
Right. So I'd say dislocations are probably extremely rare. The challenge is, so let's say you're having a prone procedure, meaning that you're on your belly. So we put you to sleep and put in a breathing tube most of the time you'll have a general anesthetic if you're on your belly. So let's say you're having back surgery on your belly. So we put you to sleep, we put in the breathing tube, and then we roll you onto your stomach. So in the process of putting you to sleep, one of the drugs that we give you paralyzes your muscles. So now your muscles have even less ability to help support your
Got it.
joints. And this is always a multi-person process. It may not seem like a big deal, but taking a limp, asleep body with, excuse me, with lines, you've got different things, you've got the IV, you've got the breathing tube. If nothing else, you have those two things. Usually you disconnect just about everything else. And then you roll them onto their belly. This is not a 2 people thing. This is like at least 4 people. I'm trying to think how many people, depends on the size of the person, but you may have 1, 2, 3, 4. You probably have like maybe 5 people doing this. So if one person pulls something one way and one person pulls something the other way, to me the bigger thing is like the shoulders, right? Shoulders or the elbows are kind of at higher risk in that case, or like maybe a wrist. And then we position the arms either like up like this or down by the sides, depending on what type of bed, etc. Frank dislocations, I believe, would be usually recognized at the time, unless somebody has something that slides in and out so easily that it goes back into place and nobody even realizes it. But a subluxation, I bet, happens a lot more frequently. And I also believe that people who have EDS, Marfan's, other connective tissue disorders, and even those that have HSD or hypermobility disorders are also possibly at increased risk of neuropathy or a nerve problem following surgery, like a compression type injury.
And for the listeners, what's the difference between a subluxation and a dislocation?
Sure. So a dislocation is when a joint completely comes out of proper alignment. So like a good example with the shoulder, normally the head of the humerus comes out in front, and if it dislocates, so if a joint dislocates, the bones that normally are lined up a certain way, they have completely come out of contact with each other. With a subluxation, the bones are not in proper alignment, but they're also not completely out of contact with each other. So it's kind of like a partial dislocation, if you will. And it's important also to make a distinction between hearing cracks and crackles and noises, right, that can come from our joints and our bodies. That doesn't mean that there's a subluxation. That happens all the time. And most of those, even in a body with a connective tissue disorder or a hypermobility disorder, most of the time, those noises that come from the body, they are not a dislocation or a subluxation.
Cavitations, a lot of times.
Yes. Yep.
Release of gas in the joint, I believe.
Yep.
All right. You brought up so many good things that I want to get into, but I'd love to hear the rest of your diagnostic kind of journey.
Sure. So when I had my Tarlov Cyst surgery, which involves a sacral laminotomy, so I was prone for that surgery, and they actually cut open my sacrum. They actually take the sacrum is a solid bone, right? Or it's supposed to be. So they make a little porthole. They take a piece of your sacrum out, which at that point was very thinned because of this cyst. So they did that. They treat the cyst, they drain it, and then they wrap it with what's called bovine pericardium. So that's
Hmm.
from the lining of the heart. They wrap that so it doesn't re-expand. Put the porthole back on, and then sew everything shut. And so I didn't know at the time that I had the surgery that I had this. It was only afterwards, and I was doing the reading and stuff like that, that I started thinking, I wonder if that, could be the case. And so it was I really started to put all of that together as I was reading. I was like, oh my gosh, throughout my life I had so many gastrointestinal issues. When I was at the Mayo Clinic, multiple times I was tested for porphyria, and I was scoped a number of times, and I had a lot of different GI things going on. Nobody ever put that together with my eczema and my allergies and my flushing and hives and waking up with urticaria, or just like all night long, like you're just like going crazy with, I mean, my allergies were so bad. And I did go through the whole like desensitization shots. They could not get me up. I could not complete the series because I was having so many reactions to the shots. But they did help a lot. I believe that they helped with my asthma and with my allergic rhinitis and with my eczema and all of that stuff. So that part was good. Yeah, I've definitely had tons of orthopedic things. I've had tons of surgeries. One thing that I'm very fortunate to really have this perspective, because not only have I worked as an anesthesiologist and I've been a patient, obviously, I also, for a period of a number of years, I did something called locum tenens, which means that you go around to different hospitals working as like a substitute teacher, if you will, like a substitute anesthesiologist. So, especially in small groups, if they have somebody out on a medical leave, then they need to bring someone in to cover. So, I've worked in tons of different hospitals. And so, it's not just a narrow perspective. I feel like it's a pretty broad perspective. And I started realizing and thinking to myself, there's a lot of people having a lot of surgeries. And I'm really wondering how many of these surgeries are really that effective. So if we took a scale and we said cataract surgery, almost always successful, rarely complications, huge improvement in quality of life. So you could have somebody who's 98 years old, all kinds of medical problems. It's a low risk surgery. If they can now see the TV, like that's a huge success. And then you have back surgery for back pain. No, that's a really bad idea. So, and then all the other surgeries kind of in between. So I think I also really started to realize that a lot of people with connective tissue disorders and hypermobility disorders may be undergoing procedures and surgeries that may or may not really address the root cause of their problem. And so they may or may not get the outcome that they're looking for, like what you said about the wounds. And that doesn't mean it was the wrong surgery, but it does mean that you are maybe at higher risk of a complication. And most surgeons are not aware of that. So they can't advise they can't advise their patient on something that they don't even know about. So I think it's very important for people with connective tissue disorders or hypermobility disorders to really understand as much as they can about surgery, about anesthesia, so that they can make so at least they can ask more of the right questions. So that's also why I wrote an article with Dr. Pradeep Chopra on that topic. And then I also wrote a chapter in the book called Disjointed. I wrote a chapter on surgery and anesthesia.
Yeah, that I've read both the article and the book. That book is, I have like almost every page earmarked, I feel like, in tabs and just highlight and notes. And that was just such an incredible book. Really great resource that we can also put in the show notes for folks. So, in your opinion, do you feel like a diagnosis is helpful overall for people?
It helped me tremendously. I had no idea what the term gaslighting meant until actually fairly recently. I have to admit, I was definitely gaslit, and I gaslighted myself. Now that I know what that means, I definitely was doubting myself because I had so many people around me that were doubting me. I had my doctors who wouldn't listen or believe me. I had my colleagues in the operating room that I was working with, most of whom did not believe me. I had a few that were wonderful human beings who were compassionate and understanding, but most of my partners at that time did not really understand what I was going through and didn't really empathize. And it's hard on family and friends, and I did not realize how somebody living with somebody with chronic pain, especially back in, I'm trying to think if I get the years right. Let's see, back in 2000, let's say 10-ish, 2009 is when everything really fell apart, like this last spiel. I fell off a mountain bike and I tore a bunch of stuff in my knee, and kind of one thing led to another, and that's how the Tarlov Cyst, like, run into problems with
Mm.
that. And so it was in 2009, 2010 that I had major, major pain brain. I mean, it was all I could think about. It was all I talked about. And I did not recognize how impactful that was on my family and on my friends. And now I have a different perspective, of course. And that's part of what I try to help people with is settling down that pain brain. Pain is designed to get our attention, right? But when it's there day in and day out, and if you're somebody like me who has a pretty active limbic system to start with, as a lot of us do, then those signals can be interpreted in a way that danger, danger, danger 24/7. So when I first learned about central sensitization and pain catastrophizing, I was like, oh, okay, I can change how I feel by changing what I think. That's pretty cool. I'm going to try that. And I was kind of like over pretty significant period of time, but then I was able to really get myself to feel a lot better in combination with doing a bunch of other things, working on my diet and,
Mhm.
Mhm.
changing some medications and supplements and things like that.
Yeah, I think that is probably one of the most impactful things that we found in our communities. We've been making programs to help people with chronic pain since 2016 was
Yeah.
Andrew's first one. Not specifically for people who are hypermobile, but just people with pain. He had a big
Which I wouldn't be surprised if most of the people were hypermobile, but
we did start to notice some things, but yeah, teaching people. I was actually a member of his first program, which is how we met, and I remember him talking a little bit about that and saying that there's a difference between feeling pain and having damage occurring to your tissues. And what
Mhm.
are you visualizing when you're feeling a sharp stabbing
yes.
pain? Are you visualizing if it's in your back, like your disc exploding, and
Yeah.
or
Yeah.
what is it? How are you picturing that? And can you differentiate between, is there actually tissue damage, or are you just feeling the sensation that there's no real harm? There's no, like, you can kind of just dismiss it. And how does that impact the way that you experience that pain? And that was
Yeah, and
pretty
your
impactful.
mountain biking accident's a perfect example of this is traumatic injury. Like you cause damage to the tissue. Whereas a lot of people will wake up and they're like, I took a step out of my bed and my back just went out and I know that I tore my disc again. And I'm like, you took a step.
And they tend to do the catastrophizing of like,
Mhm.
I'm going to be out of work and and so just
Yep.
a lot of times getting people to realize that most often in a couple days you're going to be feeling way better. So let's not get ahead of ourselves and start planning how bad this is going to be. Let's just focus on the things we know that help, and breathing, and let's go back to looking for those little 1% improvements and focusing on the silver linings. And
Hmm. So we're on the same page there.
yeah,
And,
I
yeah.
sorry, go ahead.
And Andrew, I'm so glad that you also have programs for people with chronic pain, whether or not they have hypermobility, because I do really believe that anyone with a chronically painful condition, if they can understand that if you feel discomfort, if you can try to perceive that as information coming from
Hmm.
your body, and what might that information mean? Because sometimes it means you should make a change. Okay, I've had kind of an issue lately with my neck, and if I try to do certain like soft tissue stuff, it flares up my
Yep.
medial epicondylitis. But if I just go calmly, okay, there's no damage there, but that's just telling me that I should not continue doing that in that way, because if I continue to do that, then maybe I'm going to run into a problem. But I'm so glad you brought up specifically about discs, I cannot tell you how many times people tell me about all their herniated discs. And it's like spines, that's what they do over time. And there's a fascinating study where they looked at, so they took two groups of people, and in one group, they read the radiology report exactly as they normally would. And in the other group, they read the radiology report as they would, and then they added a sentence that said, these findings are typical for a person of this age. Okay. And these were like matched groups.
Yeah.
Well, what's coming next? The people where they added that sentence, they did better than the people who didn't. So I think so often we now, especially nowadays, we can read our own medical records in a lot of instances. And so and then we Google stuff, right?
Oh,
And
yeah.
then we go, oh my God, oh my God. And it's normal. I mean, that's a normal thing. And especially because we have so much difficulty getting time in front of our doctor. So we feel like we need to kind of do some of these things sometimes, but we can end up kind of misinterpreting what we read and thinking that this is something that's abnormal. We all age. Every body is going to
Yes.
go through the aging process. I mean, what's the alternative, right? We either age or we're not here. And of course, there's things that we can do to help improve that. But I think that your disc example is such a perfect one because of the fact that just because somebody has there's a lot of fine details in there that are so important.
Yeah, and to go along with that, I believe I don't remember the study, it was done a while ago, but they took like 100 people and they just MRI'd their knee. None of them had pain, and a majority of them had tears of various kinds all over the knee,
Yep.
and they didn't experience pain. So, I mean, people send us MRIs and X-rays every
We're
week,
like, don't do that.
and
We're not medical. Don't send us medical.
we don't give them advice, but what I often tell them is just because it shows up on the MRI or X-ray doesn't even mean that that's why you were experiencing pain in the first place.
Exactly.
So they found something like, aha, I'm going to put
Right.
this is the reason, when it may not be at all.
Yeah.
Yeah, I think my opinion with diagnosis, I think in my experience, it was really helpful for some of the similar things that you said. I think even when it came to family, I grew up in a family of doctors and nurses, and I felt like my family always kind of treated me like I was a little bit of a hypochondriac, like, oh, Katie's got something wrong with her again. And there's pictures
Right.
of me as a toddler with my arm in a sling because I couldn't use it, and I had a bunch of issues with my neck as a baby, not holding it up. And I just felt like I kind of had that, I don't know, kind of just dismissed even by family. And then when I was diagnosed, my family started to look into it and read about it. And they were like, well, wouldn't you, that explains this and this. Wow, there really was something going on. And I think that was very validating for me. And I also have a personality where I tend to dive deep into reading and learning everything that I possibly can about a topic when, something comes up. And I did that with EDS, and I joined a bunch of support groups, and I kind of had to take a step back because I found I know you've talked about this too. There are groups that are focused on making improvements, and then there's groups that are just focused on the negative aspects, or it almost becomes a competition of who has it worse, or it just put me in a very negative space mentally. And I think I began reading so many papers and medical literature too that I started to think about my neck and just immediately went to worst case scenario. Oh my gosh, I'm
Yep.
going to need a fusion, and
Yep.
and it just wasn't helpful. It gave me a lot of anxiety. I got very depressed. And that was about the time that I met Andrew and started doing his program. And then when I saw how bendy he was, and then when he got diagnosed and I saw the way he was living his life, it I guess it allowed me to just kind of go, okay, I went my whole life up to this point without being diagnosed, not knowing that I had this thing. And I was active. And I know that when I exercise and I'm strong, I have less pain in all of my joints. I know that when I sleep better, I have less pain. I know. So I had to kind of take a step back and focus on the things that I knew made improvements, and kind of go a little bit reverse on the kind of fragile mindset. Like I sort of got into the space of I'm
Right.
fragile. I can't do that. I don't know if I should do that with my EDS. And he challenged me a lot on that. Like, people without EDS get hurt all the time too. What's better? Lift weights and be strong and maybe get hurt, or not, and then you're weaker and then you just have worse pain all the time and other issues like so. I guess I'm curious, like, what your thoughts are with pros and cons to diagnosis and what
Sure.
happens after.
And what you were saying immediately brought to mind a patient of mine who says one of the most valuable things that I ever did for her was to tell her during her first visit, I told her that you are stronger than you think you are. And she said that was a really valuable thing for her. And I totally agree with you about that. I'll get into the diagnosis in one other second, but I totally agree with you about the Facebook groups. When I was a patient and I was like on a medical leave. And so I was in some of these Facebook groups. I am very suggestible. And next thing I know, I'm like, oh my God, I have CCI, I have Chiari. And then I was like, I have to just not read this stuff. And then I felt better. I mean, and I know that like for a lot of people, obviously that's not how it works. And obviously there are people who truly have those conditions and they're really difficult to get diagnosed and get proper care and all of that. But it's important to remember for the Facebook groups, and I'm just using that as an example, but for a lot of the support groups, the people that are writing on there are the ones that are doing the least well because they're really struggling and suffering. And the people who are out living their life, they're not taking the time to be on there. And they're not necessarily coming back on and saying, hey, I'm doing great and this is how I got there. A lot of times they either can't bring themselves to go back to that terrible place that they were at. I have patients like that who say, I want to share my story, but I can't because I can't even bring myself to think about how incredibly sick I was. So yeah, I think that can be one of the challenges of our online environment. When it comes to the pros and cons of diagnosis, though, I think that you're right. It can be incredibly validating. And for me, it certainly was. It was very, very validating to know that there was a name, to put a name to what it was that I had. Really did make me feel a lot better because I was starting to think maybe I am lazy or crazy or, but
Yeah.
yeah. So I think in a lot of regards, it can be very, very beneficial. One of the potential downsides is health insurance. I mean, health insurance, if I know like now I'm not a health insurance law expert, but I believe that pre-existing conditions that's not as much of a concern as it was at one point in time. But when it comes to life insurance, that is definitely something that people can have difficulty with. When my husband and I went to buy life insurance and they would not insure me. They were happy to insure him, but they would not insure me. So even though I have hypermobile EDS, I have no sign of a vascular fragility problem. But a lot of the insurance companies don't understand that difference. And I also am an advocate of assessing. I think pediatricians should be really knowledgeable about hypermobility. They should be assessing for joint mobility and helping maybe have programs to send kids to work on proprioception and strengthening and muscle tone and things like that. But I don't think we need to start going and labeling kids at a young age because kids are so flexible anyway. We don't necessarily know like what are the norms in kids. So I think we want to make sure that we keep a proper balance of getting the person diagnosed with the proper things so that they have the access to the resources that they need. And also keeping in mind that these things are going to change over time. The 2017 criteria is already being revisited, and that wasn't that long ago. So medicine is such a rapidly evolving field. And so I think it also is important for all of us not to get too overly attached to one label, because what if that label changes? And if you really attached a lot of your self-esteem, self-worth, validation to that one label, and now I have one particular patient who is pretty heavily in the EDS world, and it was like, oh my gosh, you might have something actually very different as we were going through the workup. And it's like, well, now what's going to happen?
Yeah.
Well, because there's things that look, yeah.
That brings up a good point. I guess people sometimes, what I saw in some of those communities too, were people who became very identified by their diagnosis, kind of like I felt like an unhealthy attachment to that diagnosis. Like it defined them and really just was such a huge part of who they were. And that was something that was interesting to me. And then also wanted to touch on language. And that was something that I also saw in those groups. And even sometimes the way that people with EDS will refer to themselves. And I think there's so much power in language. And that's something that we go through with
I
our
teach that a lot
communities.
in our
Yeah, a
communities.
lot of the way we talk about ourselves, about our bodies is really powerful and people don't realize that. And I sometimes see shirts for EDS and stuff that say like fragile body. And I get it. And I know, yes, we are more prone to being injured. And I understand the reasoning behind it. But I'm also like, how can we put a positive spin on that? Resilient AF or something. Like we're super
Right.
resilient. That's a positive thing
Right.
versus these just words that I see attached that I mean, I personally, chronic pain is not a phrase I like. It to me, it just gives a negative. Having worked in healthcare and stuff, I don't know. To me, it just has a stigma with it, and I feel that way a little bit about chronic illness too. And I'm just curious what your experience has been. And I know you've been a huge driving force in
Mhm.
that, really looking at language and the impact that it has for people.
I think words are so powerful. I think that the I can't remember how old I was, but I was pretty old when I realized how powerful self-talk is. And I don't think we really think about self-talk, but we do. We talk to ourselves, right? All the time. And we can have negative self-talk, which I was going through a lot of negative self-talk when I was kind of not doing well in 2009, 2010. It was kind of what, again, that's probably the lowest point in my life. And that's where CBT, cognitive behavioral therapy, something like that can be hugely beneficial because if you learn about the dangers of black and white thinking and labeling and the dangers of the negative self-talk and how to reframe things. So I remember going to my physical therapist once and kind of I was beating myself up because I hadn't done my nerve flossing that week because my schedule was busy or whatever lame or not lame excuse I made, whatever. But I was going through and telling him that, and he was like, "Well, let's reframe that. Instead of beating yourself up over the fact that you didn't do this thing, and you just said you're doing pretty well, let's reframe that to, hey, I'm doing really well, even though I didn't do blah, 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 which I want you to keep doing it. That's not the point. I do want you to do those nerve glides, but we really can make a choice of how we talk to ourselves. And I think that's super important, especially because so many of the patients that I see, so many, I had no idea before I opened my practice, so many people who are really struggling with chronic pain and are having difficulty. And I also, Katie, I also hate that combination of two words because it does sound like it's never going to go away, and I
Mhm.
don't believe that that's true. I believe that in many cases, not always, but in many cases, people can vastly improve their quality of life, and they can vastly improve their, functional capacity, which to me, it's all about those 2 things. It's about your functional capacity and quality of life. I do not ask people, for the most part, what number on the pain scale because to me, that's meaningless. You could have 0 pain, but you can't open doors because you have so many problems with subluxations in your upper extremities or something and pain. But to me, it comes back to, are you able to do what you want to do? Are you able to talk to yourself in a way that is helpful? Because a lot of people have trauma in their history, and this is an extremely common thing that I find. And they have not processed the trauma, and the trauma is really it has laid an imprint in the brain that has primed the brain for chronic pain. And if we don't address the trauma, the chronic pain is not going to get better. So if those two are coexisting, then we need to address both. Just like if anxiety or depression is coexisting with chronic pain, we need to address both. We need to address all of those things that are going on.
So I see this a lot with people in our community is they will have a sudden flare up and they call it setbacks. We call it a learning experience.
Love that.
because I actually got that from a member named Kavita. She changed it for us many years ago. Um, and people will say, I've had this flare up, and they focus so much on the movement and the massaging and heating the area and all this stuff. I'm like, well, what else is going on with your life? Well, I just lost my job. Someone died. I had to move. There was a huge life change, and suddenly this thing pop almost every single time. I see that in our community, that there is an emotional component or a stressor or anxiety that is coupled with that injury, on top of also shifting the words. And one of my favorite things to have people do is change the word but to the word and when you write out a sentence and you say, I want to walk to the mailbox, but my knee hurts, you're now combining those two things together in your mind. So even just the structure of language, you're combining those two things. If you say, I want to walk to the mailbox and my knee hurts, those are now two separate subjects that are not actually literally linked together. So those are some examples of things that we change in how people are communicating with themselves, quietly in their head as well as speaking aloud. So
That's brilliant. I love that. And I can't tell you how often people tell me that they had a flare, and we'll go through and talk about what potentially could have caused that, because I think that is one thing that they want to know why, right? And I think you're absolutely right. We tend to not think about those other aspects that are so important. And it's I think one of the common misconceptions in medicine is that if pain gets worse with stress, that it means that the pain is in the person's head. Well, pain is always perceived up here, right? I mean, that is where we perceive pain. Yes, pain comes from the tissues and back up to the brain, but actually signals go from the brain back to the body
mhm.
also and help to modulate those pain signals. But really, at the end of the day, all pain is felt up here. So things that happen up here and are processed in the body, the mind and the body are not separate.
Mm-mm.
Absolutely not. They are not separate. And anyone who thinks that they are, if you read and understand about that, to me it's empowering. And I love that you're talking about language, because rather than there's a group at Stanford that's doing amazing work in pain neuroscience, and Dr. Beth Darnell, who I interviewed on my podcast, Bendy Bodies, and she's a brilliant pain psychologist. And they talk about the power of using psychologic approaches and things like that. And I like what they're doing because they're combining the biopsychosocial model of pain. I feel like some people do too much of the biologic part or too much of the psychologic part, and it's both, especially in people that have hypermobility disorders. We cannot forget what's happening in the tissues, but we also equally cannot forget what's happening up here.
Yeah, I think the biopsychosocial model has been something that we rely heavily on even before we knew what it
Yeah,
really
we didn't even
was.
know
We
what it
didn't
was.
really hadn't reached a point where we really learned about it, but we were already focusing on really optimizing all of the factors that we can. Like, how is your sleep? How can we improve your sleep? How's your nutrition? Let's talk about that. How's your stress? What reduces stress for you, and how can we encourage more of that? And then learning about that model of pain, and suddenly we were like, well, that makes sense why people respond so
Mhm.
well to it. And I think it's empowering for people to realize that there's not they come in wanting, like, what's the best stretch
Yeah.
for my herniated disc, or what's the best exercise for
Right.
my knee, or whatever. And sometimes we'll give them, like, here's a massage you can do yourself, and it's going to probably give you some quick relief, but there's a lot more to it than that. But, when people realize that they have a lot more power and control than they think they do in how they feel and how they can function. For some people, that's very empowering. For some people, it's daunting. It's like you kind of
Mhm.
have to give people as much as they're ready for. And I think that with some people, taking responsibility and ownership can be challenging, because when you go to someone else looking for them to fix you or make you better, go to the chiropractor or the physical therapist or the massage therapist, that relieves some of the work that you have to put in yourself. But when you get people to get excited about how much room for improvement there is when they're willing to take some ownership and look at, well, your pain's always worse after the weekend. What are you doing on the weekend? Or you're going out to the
Influence.
brewery and drinking a bunch of beer and eating a bunch of food that isn't isn't great. You're not sleeping well when you
Mhm.
do that. It's challenging people sometimes, I think, is some people are more open to being challenged than others, but
I think a lot of people come around though. Even I often challenge people, sometimes a bit more intensely, and they may shut out. They won't respond, but they often come back around and they're like, yes, that was 100% correct. I started implementing that and it's made a huge impact. So it's great.
Yeah, and I like for what you're saying, Katie. I totally can relate to, and people will say the same thing to me. And I don't say you can't drink beer, but I try to help them find those correlations and say it's your choice.
yep.
Because if you tell somebody they can't do something, guess what? They're going to want to do it. So
Yeah.
but if basically, I feel like my job is to help them interpret the science. My job is to help them interpret the messages that their body is sending them and helping them put all that together so that they can make the choices that will be most appropriate for them at any given time and understand the cause and effect kind of thing. Yeah.
I have a question for you. Okay, you just said something like if you tell them they can't do it, they're going to want to do it, or if they literally don't, then they are depressed and they're not fulfilled. Do you still dance? Is that something that you care to do?
So that's a great question. So I discovered, well, I don't remember how many years ago it was. I discovered Zumba, and I became licensed as a Zumba instructor. And I
Cool.
love, love, love Zumba. It is so incredibly fun. But I also have to be very careful because if I just let myself go and have a great time, I one time I ended up like paying for that for months,
Hmm.
and other times for a shorter period of time. So I have to kind of hold myself back, but that's the kind of dance that I do nowadays, and I love it. It is so much fun, and like I said, I wish I had discovered it sooner. And you can do it in the water as well as doing it on land, but it's just you're moving to this fantastic music, and the choreography is like super easy to learn, and so there's no let's stop and learn the steps and then do it. It's like Simon says, you're just doing a mirror image of what the instructor is doing, and so that's I don't do ballet anymore. I haven't done it in a long time anyway. Maybe after I move to Colorado, I'll take an adult ballet class. We'll see.
I did bar a
Yeah, I
bunch
was
with
gonna say,
Katie,
have you
and
ever done
I have
bar
not. No,
classes?
it's
no.
obviously the easier variations of things that are in ballet, but
It's like a mix with Pilates, though, which Pilates to me has been just so helpful. But
so do you combine, are you currently doing other forms of fitness as well?
I am. So I am back in physical therapy. I consider myself a lifer. So I go in, I go out, I get depending on where I'm at, but I'm back in physical therapy, and so I do those exercises every day. And I was telling my physical therapist the other day, I think if I did all of the exercises that I've been prescribed to do, even if you just discount the ones that are like not relevant right now, but if I did all of the ones that I really should be doing right now, I could probably fill like every day doing that. But so I do that. I do my physical therapy exercises, and I intermittently will do Zumba, and I also go for lots and lots of walks. I love walking. Fortunately, we have a dog, so we take the dog for lots of walks. Sometimes in the summer, he's not too keen on it, but I try to get outside as much as I can. I try to exercise in the pool as much as I can. And after my move, I'm going to have so much more ability to do that. So I'm super excited about that. And sometimes I'll hop on something like an elliptical or an art
Mhm.
trainer or something, although I try not to do that too much because of the repetitive motion in one plane kind of a thing. I feel like the endorphin rush that I get from doing Zumba, again, I have to keep in mind like that while you're doing it, you have the
Yep.
exercise induced hypoalgesia, which is the opposite of opioid induced hyperalgesia. So while you're doing it, you're not feeling it's like you're sitting on the beach and you're getting a sunburn and you're not aware of it. While you're doing the class, you might not be aware. So I tell people all the time that it's not what can you do, but what can you do the next day?
Mhm.
Can you do that same activity the next day? Or in the instance of strengthening your muscles, we know that you can get DOMS, delayed onset muscle soreness, which is a great thing. In fact, that's my goal after I move is to have sore muscles again. It's been a while since I've been able to work my muscles hard enough without hurting my joints that my muscles are sore. So I don't want to say that's an exception to my rule, but that's if your muscles are sore, but you can still walk the dog and stuff like that. That's very different than if you're in bed because you can't do anything. So I think that I'm hoping that I'm going to be able to do a lot more once I'm in a permanent location. Right now I'm in a rental house and we knew this was temporary. I really want to get with somebody to be able to do Pilates on a regular basis. As you mentioned, Katie, I love Pilates. My co-host Jennifer Milner is a Pilates instructor, works with a lot of pre-professional, hypermobile ballet dancers. She coaches them and she's an amazing resource for bendy dancers. So it's to me, it's like constantly adjusting the program to best fit wherever I'm at that point in time.
We kind of encourage that with the test and retest with people in the community. As far as introducing like new activities, it's kind of the
Mhm.
test. Try something, like go easy with it, try it, and then see how you feel. And then use that as a gauge of whether that's something you should do again, or maybe you need to modify it further. Trying to teach people that because a lot of people will say, hypermobile or not, went and joined this group exercise class, but then I got hurt and then I couldn't do it. Like every time they try to go and work out or strengthen, they get injured. So then they stop. And so
Yep.
trying to help them ease in gradually. And that's where we really start with the very, very basics and foundational movements to build people up, but also to help them learn their own thresholds so that they're
Mhm.
not relying. But a lot of times by the end of the program, people are better at coming up with their own modifications
Mhm.
or advocating for
Mhm.
themselves than versus relying on the group exercise instructor. Like my wrists hurt when I do this. Who knows what kind of modification you're going to get, if any. But when they know they're for themselves what they can do, it's just we find good outcomes with that.
Yeah, treat yourself like a science experiment is kind of what we
Yes.
use, and really just explore the capacities of, well, your capacities, not necessarily comparing yourself to other people and what they're doing,
Mhm.
but really just constantly having this explorative approach to movement, and obviously your mindset, mindfulness, and being as open as possible to all types of movement.
Mhm.
I did CrossFit for 7 years, and if I had done CrossFit, a majority of CrossFit coaches, I would not have done CrossFit. But this guy started me from the ground up. He saw that I absolutely had no idea how to move my body. This was post disc injury. So I had herniated my disc, L4, L5, 10 millimeters. And I had sciatica down both legs for a couple of years. And
Mhm.
he's like, you need to come to my gym. And I'm like, why would I do that? CrossFit hurts people. And he's like, no, 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 not the way I do it. And he
You
took me
didn't
in,
have a
and
weight for he didn't give you
I
weights
didn't have
for
a
like
weight for months, and he just slowly worked me up. And so I'm grateful that man taught me a significant amount of about what I know today. And his name's Mike Koopman. He doesn't train or do anything physical anymore. He's military. Yeah, those people, you just have to keep exploring and looking for those kinds of people that are willing to start you at the ground level and
Mhm.
slowly work you up over time. Very patient, meticulous people.
Mhm.
Yeah, I think that approach is great. I know for me, even going to physical therapy, I've had a couple physical therapists before I was diagnosed with EDS that I would go to them for a hip issue and they would do like stretches and stuff on my hip that would just make it worse. Or I go to a chiropractor and get something adjusted and then I would be like miserable for months after the adjustment. And yeah, it can be good to just start small. I'd love to hear that more about the acronym now, the MENS PMMS that you use. Do you mind going over what that acronym stands for?
Sure, I'm happy to. So my practice I'm an anesthesiologist. Most anesthesiologists that do pain management are interventional pain management physicians.
Hmm.
So they're doing epidurals and all kinds of stellate ganglion blocks, what they're doing all kinds of blocks and trigger point injections, those kinds of things. And I felt that there were enough people that were doing that. I've done lots of epidurals over the course of my career and some of those different things. But I really felt that somebody needed to take a medical approach to treating people with, I like to call it persistent pain. That's what I
Hmm.
used to call it, or I try to remember to call it that. That's what I like to call it. And so when I'm working with somebody that has persistent pain, I feel like it can be helpful to help them remember and for me to remember the different parts of their care plan that make it a comprehensive care plan as opposed to usually if you go into your PCP or somebody else and you talk about your persistent pain, they don't have that much time. So they kind of have to give you like a couple quick things or one, like they'll write you a prescription for an anti-inflammatory and off you go. But for me, what my goal is to help people develop a comprehensive plan. So the acronym is MENS PMMS. So the first letter M stands for movement. That's because movement to me is absolutely the key. And it's moving better first and then moving more. So just people just going, and I love what you said, Andrew, about that we are each our own science experiment. That's brilliant. I love that because it really is so, so true. What
Mhm.
works for another person is not going to be what works for you. So learning how to listen to your body, learning how to move in the proper way, learning how to use the correct muscles for XYZ movement. Because I think oftentimes people forget that they want to be able to move around and do their day-to-day things, but they forget, like, if you just sit on the sofa all day, that's not going to happen. Like your muscles are not going to be able to do those other things for you. So we have to keep moving if we want to move. So that's the first letter. The second letter, E, is for education. So it's the pain neuroscience. It's understanding what's pain catastrophization. Why is trauma so important? Why are anxiety and depression so important? How does the processing of pain signals work? Why does stress make pain worse, regardless of the cause of the pain? Things like that. The N stands for nutrition. What are the different variables of the food that you're consuming that may be impacting your pain? Every single time that we eat, we change the chemistry in our body. So, what are we eating that could be making our pain worse? What are we eating that might be making our pain better? And kind of sorting some of those things out. Also, keeping in mind, though, we want to make sure not to push someone into disordered eating. So we want to be, thoughtful of that, especially because I work with a lot of dancers and they're at risk for that already anyway. And then the S stands for sleep. Super, super important. As you already mentioned, Katie, so many of my patients are sleeping poorly or they're sleeping during the hours that they should not be sleeping. They're going to bed at 4 in the morning or 5 in the morning or 6 in the morning. They're going to bed at that time. And it's no, your circadian rhythm is so important. And I understand some people are night owls, but you're working against biology when you do that. So working on getting better quality sleep, getting restorative sleep. Do they need a sleep study? Are they having obstructive sleep apnea? Are they having central sleep apnea? Are they having sympathetic nervous system, dysregulation while they're sleeping? Things like that. So that's the first word, the MENS. And then the P stands for psychosocial. Does the person need to get into some kind of a support group? Would they benefit from one-on-one counseling, which I believe that everybody deserves to have that, and that's a very important thing for every single person. And there should not be stigma attached to that at all.
Correct.
I think people are brave that I mean, I see a counselor. It's helpful for all of us, no matter where we are at. It just gives us somebody that we can bounce things off of and somebody that we can just it's a confidential place that we can share our thoughts and our feelings, and it can help improve our relationships and things like that, and our relationship with our body. So that's what the P is for. And then the next M stands for modalities. So that could be working with like red light laser, acupuncture, acupressure, foam rollers, Graston technique, and different types of things like that. And then the next M, and you'll notice, and this is for probably, I made this confusing before. So Katie, I appreciate you pointing this out. So this is the third M, but it's the second M in that second word. So it's MENS PMMS. But I like to point out that it's the third M because it's medications, but I intentionally put it as the last M. The mistake that I see a lot of people make is they think that they're going to get some magic pill and that there's one thing that's going to fix all their problems. And unfortunately, we don't have that magic pill yet. And I don't see a magic pill coming anytime soon on the horizon. So that's why I feel that this more broad approach is helpful. So that's medications. It can be a wide variety of different things. And then the last letter, S, is for supplements. And also, I had sleep before supplements because no amount of supplements is going to make up for a poor diet.
Nope.
And although supplements can be useful for correcting magnesium deficiencies or stabilizing mast cells or helping with micronutrient deficiencies, or maybe you live at a high northern latitude and you don't make enough vitamin D, things
Hmm.
like that. So that's the acronym that I use.
That's great.
I love that. And I love that you intentionally, I love the description
Ordered
of
them.
why the third M is medication.
I do want to point out the psychosocial part, the getting therapy. I just want to say that both Katie and I have had extensive self work. We've done a lot of work,
Mhm.
seen therapists, even had worked with a couples therapist, and
Mhm.
it's just really important stuff because you don't know what you don't know, and it's
Right.
really helpful to have someone point out your blind spots and to be able to think more openly. So I'd
Yeah.
encourage that
I
for
think
sure.
so many people also treat or think about therapy as something you do when you have a problem,
Yeah, I've
and
never
thinking
really had
about
a
it,
lot of
like people
problems.
were like, "Oh, you went to a couples therapist? Like what was going on?" And we're like, "Well, nothing, but
Want
I don't
to
know. We
get better
wanted
at
to,
being a
yeah,
couple,
we
you know?
wanted to really kind of invest. We both had relationships that
Mhm.
didn't work out, and our relationship is really important to us. And the healthier our relationship is, the better we can show up for our kids. And so I don't think you have to have a problem per se to go
Mhm.
do
Correct.
therapy.
If you wait until things get really, really bad, then it's a lot harder. So
Yeah.
that's why I say to people, you deserve to have a counselor.
Yeah.
You know,
I think
yeah,
it's,
yeah.
I think getting established with a therapist. Uh-oh, do we have a sneeze happening?
Oh, good.
I think getting established with a therapist is, in my mind, a lot like getting established with a good primary care physician. And I think
Mhm.
sometimes people maybe that don't have any medical background don't necessarily realize the importance of that. But if you're established and you already have a good rapport and they know about you, and then when you do have something flare up emotionally, and you can go to this therapist who you already trust each other, you already know each other, and you can say, here's this thing that happened. You don't have to start over from the ground up building this whole relationship. And same thing with a primary care physician. I know that's something that I get on you about because he's like, I'm healthy, I don't need one. And I'm like, no, you do need one because you're healthy until you're not. What happened if you got in a car accident tomorrow? Like, you still need someone orchestrating and advocating for you and able to refer out. Like, when you get discharged from the hospital, it's always follow up with your PCP and then these
Yep.
specialists. And you just have to have that. And I think so
Mhm.
many people don't understand that.
Mhm.
Um, I also really like with the medications being kind of de-emphasized. I think we're in this world on social media where there's a lot of, I would consider us to be more along the lines of like integrative or holistic, or,
Mhm.
and I think there's so much all or none mentality. People are very anti-medication. Medication is bad. Pharmaceuticals, big pharma. And I think that it's incredibly helpful in some cases, absolutely essential for people. I think with my nursing background, I would often see patients who would come in with a bag full of medications that they couldn't even tell you, I don't remember what that one was for. And it was
Mhm.
like, I take this one for the side effect caused by this other one for
Yep.
the side effect caused by this.
Yep.
Okay, like you need to almost get a clean slate and really look at what do you actually need. And I think again, that's where the primary care physician comes in, because some of these people, it's like, well, that was prescribed by my neurologist. That one was by my dermatologist. That one was by my pulmonologist. And no one, they weren't getting an accurate history of what meds they were already on. And so
Mhm.
it's, you have to have someone just overseeing all
Mhm.
of that.
Totally. Totally agree. And sometimes people they'll get a medication that's PRN, so it's on a as needed basis, but that isn't communicated
As
properly.
as needed. It means you
Okay.
just take it.
Yeah. So if on your prescription it says PRN, or if the pharmacist I think usually writes out as needed, but like when I write a prescription, I might write PRN, like there's a box to check for PRN. But if that doesn't get communicated effectively, I see this all the time. They're taking this on a regular basis. They're taking it every 6 hours or whatever. And it's like, no, 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 no. This was only supposed to be if you really needed it. So now they've got, and you're exactly right, Katie, about the taking this to offset that. And next thing, they've got so many things going on that it's hard to sort out what's doing what. Yeah.
And I'm a fan of, there's a woman recently who said, like, I'm ashamed that I'm taking pain medication. She's got a horrible disc herniation. I'm like, no, no, no. You're taking this medication and you're also taking action
Hmm.
on improving it in a variety of ways. So
Hmm.
continue the medication. I think when there isn't a plan set in place for them to make improvements and they're just kind of taking the medication as their last resort, that's where things kind of
Or
cascade in
is
the
their
wrong direction.
only,
Their
like,
only
if that's
resort,
their
rather.
only thing that they're doing to treat the
Right.
issue, it doesn't have any future plans of coming off of it or what else they can do.
And I'm glad you brought that up, Andrew, because in our society, like the pendulum, swung from anybody with a chronic pain problem can get opioids to nobody can get opioids, even if you've had surgery. And it's,
Mm.
oh dear God. I mean, it's just swung so extreme. And I'm not a fan of opioids for 99.9% of EDS patients, except for maybe that they have a small amount at home for an acute event that happens. So they have it on hand. They don't have to then rush out to the pharmacy. I think that's totally fine. But taking them on a day, on a chronic basis, taking long term opioids, because you also have to think about what's the end point, right? Is this
Yep.
to get somebody through? Like you said, something happened, something acute happened, and you're trying to get them through that? Or is this, no, we're never going to be stopping it because maybe somebody does have an intractable pain problem. I treat a lot of people with what's something called adhesive arachnoiditis. And that's when the
Okay.
arachnoid layer gets inflamed, yeah, and starts to stick. And it can actually become calcified. And people can be in extreme, excruciating pain from this. And sometimes you can get it to reverse, although once it's calcified, no, you're not going to then. But we also, though, have gotten in our society to a point where there is so much stigma and it is so hard to get opioids, even for the patients who need it. So we need to understand like how to select the proper patients for any given medication, not just opioids, but those in particular because of the problems that can be associated with that. So yeah, we need to be careful not to paint too broad of a brush for any given
Hmm.
thing. For example,
Mhm.
hypermobility disorders or connective tissue disorders, people will they'll they may seem on the surface like they're very much alike, but once you really dig deep into the details of their clinical picture, they can be very different from each other.
Yep.
So,
On the topic of movement, so because we teach a lot of movement on social media, and I know you're active on social media too, and I'm sure the more people that follow, the more comments you get, both
mhm,
positive and negative. So we've always kind of taught posture, alignment, kind of corrective exercise. And we started being challenged by physical therapists who are very into evidence-based physical therapy due to some studies that showed that there is not a strong correlation of posture with pain.
According to them, it's all studies.
Yeah, they're very all or none. So they're saying there's
mhm,
no correlation between posture and pain, and you shouldn't ever tell people that improving their posture is going to improve their pain. So we've definitely changed our wording and our approaches around that. But I guess what I wonder, or what I'm curious about your opinion on, is do you think that that's different in the hypermobile population? I know my experience is n equals one, but I know for me, focusing on posture and strengthening in a good alignment absolutely has an impact, especially neck for me is a big one. Just resetting my posture throughout my day makes a big difference in how my neck kind of holds up throughout the day. So I'm just curious what your thoughts are on that, because I think it can be hard to be kind of under a microscope on social media sometimes,
yep,
and also know that maybe the demographic that you're referring to might not be necessarily the people represented in the studies. So
right. Well, and I think it's important to think about what is evidence based medicine. Evidence based medicine, sometimes abbreviated as EBM, looks at studies and how they may or may not apply to the a certain population. But what we forget often is really research. There's formal research, and then there's the less formal research that we learn from working with people. And
mhm.
unfortunately, busy clinicians don't have time to write papers and try to get them accepted into journals, and they don't have the contacts like people at an academic center. So if we just go by evidence-based medicine, like I wouldn't be doing anything with anybody because there's no approved treatment for EDS. There's no,
Mm-hmm.
if I just stuck to that, I would be so much more limited in what I was doing. And my feeling is every single thing that I do, I need to be constantly weighing the risks and the benefits, both for me personally and for me professionally as I'm advising a patient or a client. And so, okay, well, what's the downside of working on posture and alignment and trying to strengthen in those things? It's like when I'm working with somebody and I'm talking to them about nutrition or sleep or what some of these kinds of things. It's one thing if you're going to prescribe cancer chemotherapy. Yes, then you need to have studies to back up which is the best drug. But when you're talking about there is no pill or approved treatment for these conditions, what are your choices? You can say, okay, I don't have anything to offer you. Good luck. Or you can say, well, let's try some of these things that logically make sense and and have worked for me and have worked for a lot of my patients. And that's the evidence that I have to go on. What I know about science, what I know about medicine, the way it works with prescribing medications, oftentimes we prescribe things off label, which means that the medication got approved for one use, but we actually prescribe it for others. And physicians in the United States, we can prescribe things off label. And I do that all the time. Everything that I prescribe for EDS is off label because
Is
there's no
that
on label.
when you do that as a physician, are you making yourself more liable, or is it like risky for you to prescribe off-label medications? It seem like some physicians are resistant to doing that. I'm just wondering.
So I guess, again, as an anesthesiologist in the operating room, there were things that we did that, like one example that I can think of that I haven't researched this recently, but I'm pretty sure that this is correct, that fentanyl, the opioid that we would use IV during surgery, not uncommon layman. It was a super common, drug for us to use. This is many, many years before it ever became a problem, like on the street or whatever. But it was the most common opioid that we would use in surgery. Well, we would also add it into epidural infusions, a really low concentration for like a woman having a labor epidural or something. I believe that fentanyl is off label for use, via epidural. I think that's an example that is technically correct. If that's not a technically correct example, there are a million other examples
Mhm.
that in anesthesia you're constantly using things off label, I guess is what I'm trying to say. In the operating room all the time. You're altering your anesthetic technique for what's best for the patient, not what's best for the lawyers have approved this drug for this thing.
Right.
Because what happens once a drug has been approved, the drug company is not going to fund further research to study these other applications because they're not it's going to cost them a lot of money and they're really not going to gain that much from it. So usually they do a lot of research to get the drug on the market and then after that not much happens. So I mean, yes, you could say on the one hand it does, but on the other hand it's such a common thing in medicine. It's just I can't really think of a good example right now. Like going to a restaurant and you're ordering an omelet and you want to substitute out one of the ingredients and it's just
Mhm.
not a big deal for them. It's kind of like that. It's like, okay, you're subbing out one thing for another thing because you know that the evidence may not be there from a research standpoint, but lots and lots of people are doing that and there's lots of scientific reasons why that should be a useful strategy.
That makes sense.
Shiloh sent something saying, in fact, 1 in 5 prescriptions written today are for off-label use.
Oh, okay. He's just
He's,
looking up
he
little
looks
facts
things
instead.
up. I
So
don't
if
know.
we're leaning forward, we're just trying to see what Shiloh's sending through. I have another question for you working with dancers. This is another thing where I kind of hear two different sides of the coin. It's something that Andrew and I don't always agree on. But so for people who hyperextend, say elbows or legs, do you discourage them from hyperextending, or would you encourage them to strengthen in the full range of motion, even if that range of motion is into hyperextension?
So it depends on the joint. So before COVID, I would give talks in dance studios, and all the time dancers would be leaning back on their hyperextended elbows. And I'd be like, no, 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 don't do that. There is nothing aesthetically pleasing about a hyperextended elbow. So for upper extremities, my thinking is more strengthen in the more normal range of motion and work on improving joint alignment and joint stability and things like that, because that's not, you're not going to gain anything aesthetically. When it comes to the lower extremities, and I'm thinking of the knees and the ankles in particular, but let's just talk about the knees. Probably a lot of people listening are going to be familiar with almost like the S curve of the hyperextended knee and hyperflexion of
Hmm.
the ankle. And that has become over the years more and more desirable, like for example in classical ballet, to a point. But you also the leg starts to get shorter if you get too much of that. And it depends on if it's the working leg or the supporting leg. So let's say, for example, you're standing on point on the left leg and the right leg is the working leg. It's okay to go into a little bit of hyperextension in that right leg so that you have, that beautiful line. But the left leg, I would really prefer that left leg to be in more proper alignment and be more 180 degrees and not being a back knee kind of a thing. And that takes a lot of work on strengthening and control and things like that. So to me, is it the gesture leg or is it the supporting leg? And also working on proprioception, because we know that in people that have hypermobility, oftentimes proprioception is impaired. So you can tell a dancer all day long, stop doing that, stop doing that. They have no idea what you're talking about because they don't feel it in their body. So
Mhm.
retraining that can also be very helpful, and also helping them to understand that maybe a little bit of that is okay, but too much of it actually is not aesthetically pleasing either. So finding that sweet spot and strengthening through the entire range, but with a lot of control and more slow movements rather than you definitely don't want to be jerking into those hypermobile joints or locking out your joints, because of course that requires less energy, less muscle tone and things like that. But so we really want to work on that muscle tone and joint stability.
To be clear, I agree on all of that.
Yeah, I'm like, that's pretty
Yeah.
much the kind of conclusion or agreement, or I guess after a lot of conversations on this, I think what we agreed on is actively getting into a full range of motion and actively strengthening in a full range of motion seems fine and actually seems really helpful in our experience, but passively getting into that range of motion. So like elbows hyperextending in a plank is not really helpful if you're not getting there actively. If you're not loaded and that's your range of motion and you're able to strengthen through that unloaded, then great. And we did.
But not just like progressively loading into that. So if it is a hyperextended elbow, actively getting into that position and then resisting in deflection extension from that position progressively with very small load. But obviously, our upcoming program, I'm having people work within their mid range isometrically first, then
Mhm.
active range of motion. And then the last thing in the program is going to be active end range strengthening, which is fairly optional for, the population. But just kind of giving people the option of, if you'd like to increase resiliency in this end range, if your elbow does ever end up explosively hyperextended, are you able to create some tissue control, some strengthening in the muscle fibers to help prevent excessive injury if there is
Mhm.
going to be that?
Yeah, and I think we see a lot, even like I said, in the population that's not hypermobile, even with proprioception, and people not understanding when you say they're just unaware that they're even doing things. So in our
Mhm.
community, people will record themselves and upload a video, and we'll look at the video. And a lot of times we just encourage people, even if you're not going to upload the video, record yourself and look at it, because what
Right.
you think you're doing and what you're actually doing, a lot of times are not the same,
Mhm.
or set up a full length mirror so that you can see what you're doing. Just trying to encourage people to get better body awareness.
Yeah, that's a really good idea. Right. Better body awareness is good for everybody. And I like the idea of working on strengthening and control in that mid range first. And then, yes, because that's going to be a much better approach than, because what ends up happening with a lot of people that I see, we end up getting tighter and tighter and tighter because we have pain, then we start to not stretch, and then we can actually get a lot of stiffness in our tissues, and we can, next thing, like, you're super tight and you also have a lot of neural tension, and that's not good either. So it can be tricky to navigate. So it's really important to work with people that have the expertise that can really help you, again, interpret that information that's coming from your body and be able to conduct your own science experiment in a really thoughtful and intentional way.
Yeah, I think it's also important in the world of social media where people put out things that are catchy and get likes and comments and views. Like Andrew's deadlifting video, there were a lot of, I guess, conflicting comments. Like he said that he had EDS and he was lifting a lot of weights, and
I
some
think that was the
people
squat,
a squat
video.
video. Some people are like, you shouldn't do that, and some people are like, that's great. And I think we talked about it afterward, and we kind of said what I think a lot of these people don't realize, and what I don't know if we articulated well enough
I
in that
didn't.
post, is that this didn't happen in a month or a year or even a
Right.
decade. Like he's been weight training and building up to this for decades to get to this point. And so I think a lot of times people see things, whether it is some crazy yoga pose, range of motion, or whatever, they don't realize that this is something that people have spent decades
Yes.
being able to achieve safely. It's not something
Right.
that you just go out and try to do.
Right. And that just because I am sharing this does not mean that I think that this is a realistic goal for you, or that I'm
Yep.
suggesting
Yeah.
that you try this. Yeah.
Yeah.
Social media is very tricky.
It is.
And you're right. When you get, you guys have more eyeballs than I do, a lot more. But yeah, as you get more eyeballs, you definitely get more positive and negative comments and critiques. And sometimes it's really helpful because it's, oh, I didn't even thank you for pointing this out. I didn't, and I appreciate those kinds of things when they're done with, hey, wanted to give you an FYI. But then when it's just, yeah, it can be tricky.
Yeah. A great place to do that for listeners is usually DMs versus comment. If you're going to critique someone, like a respectful DM critique is probably going to be better received than a kind of snarky comment left on a post.
Yeah, and I think I've learned a significant amount from the people on social media over the years. I've been on Instagram since 15, and grew an account to 1.1 million followers, and there was an extreme amount of comments coming in, negative and positive, and I had the opportunity to learn a ton of
I think if you're
information.
willing
It
to
completely changed how I train people.
I think if you're willing to put your ego aside, because it can become instinctive to get defensive, and
Right.
you don't know. I know more than you do.
Well, I still did get defensive, and then
But yeah, after you get
push it
over the
down.
initial defensiveness, going, okay, there's probably a few people have commented something similar. There's probably something for us to learn here. Let's look into that. On also kind of a correlated topic with social media, I'd like to ask your opinion on party tricks. I know that's something that I hear, just the general recommendation of don't do that, don't do party tricks. I'm just wondering where, because that's another thing that we don't agree on.
But you need to clarify that. Is all I can say.
So Andrew does party tricks a lot. I don't do them very often. If we're filming, I might show something, like my shoulders show like a very clear sulcus line. Sometimes I'll show that, but I don't like to because it frequently will result in a little bit of pain afterward. Now, I don't know whether it's the fact that he's male and I'm female, or just two different people, or that he's younger than I am, or what it is, but he does more party tricks, and he says that it doesn't hurt him at all. He doesn't feel anything. And I'm kind of like, but I don't know if it's the best thing to do. And I hear some people give that advice, and he's, but how do you know? You're just assuming that I'm going to have pain. What if I never have any pain? What if doing these is actually strengthening in that range and preventing the pain? So I'm just curious what your opinion is, because it's something that we kind of clash on frequently.
Yeah, no, I definitely, this is something that I discuss with my patients who are circus artists and who are dancers. And I created a reel that was one of the more popular ones that I did on the 4 phases of EDS that I see. This is not a studied thing. This is because I tried to make it like a fun thing for to help people to understand that just because you don't have pain doesn't mean that you won't at some point in the future. So there's kind of the fun phase where you can do all those things. And so what I do in my clinic is I ask people to show me their party tricks and or depending on if it's virtual or in person or however I'm doing the assessment. But I often will either take photos of people doing their party tricks. I'll ask them to take photos. I think it's important to document those things. Like for the bite and score, touching the thumb to the forearm, I never touch people for that. I always have them do it on themselves. I know some of my colleagues will forcibly do that on people, and that's a great way to hurt somebody. So I don't ever do that. I let them do that on themselves. But I do tell people to take photos because later on in life, if someone's challenging your diagnosis or something and you can't do that anymore, I think it's helpful to have those photos stored someplace in your computer that you'd be able to find them. So that's one thing is the documentation piece. And I do ask people quite frequently to show me their party tricks because I want to see what are the things that they can do. And then oftentimes I'll be like, I'll videotape and I'll say, don't ever do that ever again. Because yeah, they're doing all kinds of weird, crazy stuff. But I think it is important to have those things documented. And oftentimes I call them circus tricks. So if you're in the circus, it's a totally different situation than if you're not in the circus. So I think it's being very thoughtful about the risk benefit of everything. So if you're in Cirque du Soleil and you're getting paid to do certain types of skills that might be risky for your body, but this is something that's like a football player knowing that they have a risk of concussion.
Hmm.
But of course, you're going to wear a helmet and you're going to do everything that you can to modulate that. But I think that if you're in the circus, you're going to have to take a little bit different approach than your average person walking around. That you should be trying to figure out how do I get the most functional that I possibly can, the best quality of life that I possibly can, and being proactive. I do agree. Don't wait for something to hurt, and it depends on what the trick is that you're doing, because that's part of the problem. It's like, if you take my sunburn example, while you're sitting on the beach, you don't feel the fact that you're getting sunburned, but even worse, you don't feel the fact that you're getting accumulative skin damage and increasing your risk of skin cancer. It's the exact same thing with joints. So if we're blessed to live a very long and full life, we want to have our joints feeling as good as possible, because the musculoskeletal factors can really be a huge problem for a huge percentage of people. I think it's a very rare person who really gets into their 90s without a significant amount of arthritis and stiffness and all of that kind of thing. So I think that those are just a lot of things to keep in mind. Is there an upside for me doing these things? And if so, what is it? And I think that it's appropriate to take a very thoughtful approach.
So do you see clinically or anecdotally people who say do a party trick in a specific joint? Do you see a correlation more with them having issues in that joint or pain in that joint down the road?
What would be ideal would be to longitudinally study people and be able.
Yeah.
I do have patients that I have had. I opened my clinic in 2017, and I do have a very small number of people that still see me now. What is that, 5 years later? But a lot of people I'll see for just a relatively short number of sessions, and then I think at that point they feel like they have enough information they can kind of take it from there. So unfortunately, I don't have from my patient population, I don't have a great answer to that question.
Okay. Okay.
But yeah, but I do feel like from my own personal self and the party tricks that I have done, because I definitely have done plenty of party tricks, I would go back and not do them.
What were they? I feel like if you're able to dislocate a ball from a socket and I see people do insane stuff with their arms and their hips. Like, I feel like that's an instance that is a bit too much.
Mhm. I would put both of my feet behind my head, and I would do that quite routinely. I would do different other things with putting my was it putting my feet. I would walk on my was it my elbows with my feet behind my head. I
Oh,
would do
jeez.
different like kind of contortions like that. I would pop my hip. I would pop my hip in and out, which I now realize is I didn't think I was dislocating it at the time, but now I'm very confident that that was snapping hip, that was not I was not dislocating a hip. I
Hmm.
was popping my IT band or something like
Oh,
that. Is I but I would still go back and not do that because that is now the hip. The hip that I used to do that on the most is the one that I've had problems with, and obviously that does not prove anything. That means nothing in terms of cause and effect. But
Yeah.
if I were to go back, I mean, I used to do that all the time. Literally at parties, I would,
Hmm.
hey, check this out, and do things with my hands and elbows. I mean, a variety of things, but the hip
Yeah.
was one that I definitely distinctly, remember. And then cracking my ankles a lot, like pulling them into extreme flexion so that they would do like a clunking thing, or my elbows, or not my elbows, my shoulders definitely used to sublux and get pretty far out of joint. I could pull things on really, really tight and get it squeeze into tight spaces and stuff like that. I just I just wouldn't do those things if I could do it over again. Now that
Yeah.
I'm in my 50s.
Yeah, I feel like in my, teenage years and 20s, that was always my shoulders always kind of grossed people out, and I would do it a lot and I never felt anything was fine. And then I feel like it was toward the end of my 30s that I started to notice that when I did it, I didn't feel anything, but then afterward, it was kind of
Mhm.
like the muscles were like,
mm,
"Whoa, what are you doing?" And everything kind of clamped down, and that's when I kind of went, "I don't know if this is maybe I should just not do that as much." And Jill Miller too, when we talked with her, I mean with her hip, she had a full hip
Mhm.
replacement and she
yeah.
had been doing crazy splits, and she
Yep,
kind of had a similar
yep.
story of, "I wish I had
Well,
known."
yeah, it makes me wonder because obviously the finger things I did a lot of, and now at this point they're a little bit tighter, and I can't do that. But I'm able to walk on the bottoms of my toes, or sorry, hyper flex, so that I'm on my metatarsals,
It just really is
and
cringy. Like,
that's something I've done my whole life. Like I'll wash dishes or brush my teeth, and I'll find that I have my right foot just kind of turned over. And I've done that since I was a little kid, and it makes me wonder about just testosterone versus whether or not me having more testosterone has prevented me from having any like issues in these areas, or if it's a yet thing. But that's another question: is how many men do you see on a daily basis that
I
have
do, yeah,
hypermobility?
I do have male patients, and I definitely testosterone is protective both from the standpoint of having more muscle mass, and so it's hugely beneficial in that regard, but there's also some studies showing that testosterone is protective in terms of pain processing as well. But we know that testosterone goes down as we age.
Yep.
So
mhm.
it's or that's common for testosterone to go down as we age. So yeah, as soon as you mentioned that, I was like, "Oh, that makes me cringy." Yeah, because a lot of those things, right, are just habits. I mean, I would be telling
Yeah.
patients, like, don't do whatever, whatever, and then I would find myself doing. I'm like, you just have to stop. It kind of there's that brief that it feels good, and then yeah, but you just have to kind of try to catch yourself. But I do have male patients, and uh, I have more female patients than male patients, though. Definitely by a lot. But I have male patients. I'm thinking of one male patient. I think he's in his late 50s maybe that only was I diagnosed him with EDS, and he was not diagnosed until now, and actually functioned pretty well until fairly recently. And is that declining testosterone levels? A lot of times people have something that happens. It's an injury, it's an illness, a concussion, food poisoning, whatever it might be, and then things it's that starts like a
Hmm.
cascade of
Mhm.
events that can involve the immune system and mast cells and stuff like that, that then next thing you know, now you're things that were very well controlled are now suddenly not.
Got it. That's good.
In someone like that, would someone older like that who probably has declining testosterone, is that a case where you'd look at like bioidentical hormone therapy or anything like that to
Yeah,
try to help? Or
hormones are so complicated. I know one of my colleagues, we were talking and he was like in favor of prescribing testosterone and things. And the challenge is in order to properly study those things, I mean, that would require a second discipline in regenerative medicine, hormone specific, because excessive testosterone in the body, well, first of all, it increased, if you're a male, it will increase your risk of prostate cancer. And my urologist husband says if a man lives long enough, he will get prostate cancer. So we know that this is a very real thing. And excessive testosterone in the body can convert to estrogen, and that can raise your risk of breast cancer. So it's kind of one of those things where I think a lot of people think that's pretty innocuous, but it's not for free. So
Hmm.
we have to be really mindful of those things. But that's where like maintaining muscle mass or getting as much muscle mass as you can is so important, because that's a healthier way of optimizing your testosterone. And hormones are very much related to the gut and gut function. So that's where, again, where eating proper foods is a much safer way of having optimal hormone levels than popping a pill.
It's great.
What I know we're getting down there on time, so I want to be respectful of your time. Just curious, what are your goals moving forward? Are you hoping to, when you move to Colorado, are you doing more in-person practice, or what's your long-term goal that you see for yourself? Are you looking at more at helping educate providers, or just really doing one-on-one with patients, or what drives you?
I would say all of the above, but in particular, I'm really trying to reach the dancers who, especially the female dancers who have just hit puberty and they're suddenly starting to get fatigue, difficulty sleeping, they're starting to get some pain, they're starting to have some gut issues, and they have no idea what's going on, and they have no idea that it has to do with the fact that they are hypermobile. And I want to try to catch, my big goal is to catch as many people, dancer or not, but I just happen to be super passionate about dancers. But I want to try to catch as many of those young people as possible and try to intervene with the right dose of the intervention. We don't need to over medicalize these people. We don't need to slap a bunch of labels on them and make them feel like they're sick or like they're a patient before they need to be, but give them the tools so that they know how to manage their body in a way such that they can have a really successful life. Because I cannot tell you how many people I see that nobody was there for them, including me, but I happen to be highly functional at this point. But I see a lot of people who they're like in bed and they can't, and could I have saved that person? I don't know. Nobody knows, right? But I see a lot of people who they really just they fell down the EDS spiral and or they fell off the EDS cliff or hit the EDS wall, whatever whatever saying you
Hmm.
want to use. And one thing led to another. Next thing, they've lost all their muscle mass. They have pain brain. Their quality of life is just horrible. And I've had patients that have been in wheelchairs that now are walking. I have patients that I had this one patient who was down to eating two foods, couldn't do anything. She wore like a heavy duty, looked like she was in the middle of, I don't know, an Ebola type thing. One of these really heavy duty masks. This was pre-pandemic, so it was kind of really unexpected. Terribly, terribly sick. And she's now back dancing. Is she dancing in ABT? No, but she's dancing. And she sent me a video of herself the other day and I'm doing really great. I can eat whatever I want. The sooner that we catch these people, the easier it's going to be to reverse those changes. And from a selfish perspective, we need people in the workforce. We need people in healthcare. We need people like the two of you who are coaching people and helping people live their best quality of life, because we're otherwise kind of headed for disaster, I think. I mean, I feel
Mhm.
I cannot tell you how many young people that I get asked to fill out disability paperwork for. And
Yeah.
This is not good. We need people to,
Yeah.
because it's also, we get so much fulfillment from being able to do work. And
Yes.
for me, going from being not able to work to being able to work and to serve other people and finding my purpose it gave me my life back. And that's what I want to do for other people. I want to be able to give them their life back. And I'm hoping that I can also do it on a bigger scale. And that's why I do the podcast and other free things, because I know not everybody can afford to come see me one-on-one. So I do offer a lot of free resources, and the goal is to have more things like classes and giving people the tools that they need in whatever the best, most efficient model is. I mean, I can sit here and tell people something one-on-one that if they could have learned it for free listening to my podcast, that's a more efficient way from the standpoint of their money and time and stuff like that. So if you can speak to a large group and get a certain amount of information across, that's great. And that should be used in combination with one-on-one, like this is what, is appropriate for you. So I just want to reach as many people as I possibly can, whether you have a hypermobility disorder or not. I am nervous about our future. And because of COVID, we have more people that are having problems with inflammatory conditions and chronic pain, dysautonomia, and all of these other things. So I really think that we really need to revisit how healthcare is serving the population. And is it really serving the population in the right way? Or what could we change that could make it better? So
Yeah.
it's a
That was
lot.
excellent.
That was
Let's see.
great. That was, yeah. It's such a tough balance, I think, sometimes too, with how much to challenge people or how to challenge people or how to describe to people. I think about something like disability, and I just wonder, is that really best long term? Like, I know it's not, you have to listen to your body and not just push through. I know that's not always helpful either, but it's like a very fine line, I feel like, between dialing back and doing nothing and just getting more atrophied and more disabled versus maintaining some level of activity and not decompensating like that. Because we've had a lot of discussions about that too, why some people say, you guys can't have EDS, you look so healthy, and have a lot of challenges from it, but we also devote our lives to being healthy. Like, we literally made it our career so that we could emphasize that every day in everything that we do. So
Right.
best place sorry, go ahead.
No, I just wanted to add a quick thing about disability. I think we also need to better serve people who are disabled, to encourage them to work in some capacity, because most people can do something. So I think that we really, if we had reform of that also, we could help people get the help that they need, but also encourage them to still do what they can. But instead, it's this all or nothing system. And yeah, it's just a mess. But anyway.
Best place for people to find you?
Go ahead, sorry.
Yeah. Best place for people to find me, my website, www.hypermobilitymd.com. I'm also on Instagram, Facebook, Twitter, LinkedIn at hypermobilitymd. And Bendy Bodies, my podcast, is on Instagram, it's at bendy_bodies. And yeah, and bendybodies.org is where you can access the podcast.
Great. We will put all of that in the show notes. Thank you so much for providing us with your time and all of your insight.
Yes, thank you. It was a pleasure having you as our first guest.
Oh my gosh, I feel so honored. It was so great to chat with both of you. And I love getting to spend time. So thank you so much for the opportunity.
Thank you.
Thank you.
Thanks for listening to this episode of the Wealth Podcast. If you're interested in getting connected with us in any way, you can look at the show notes at the bottom of this thing. I don't even know where you're watching this, YouTube, Spotify, some other platform, but look below. There's a description. It's got links on it. And you can click those links and it'll take you to places that are helpful to you.
Everything that we referenced that will be in the show notes will be in the show notes. If you would like more information from us, check out our website, www.spreadwealth.com. We also have links in the description for all of our free resources that we put out, including our blog, social media channels, And if you want to see Andrew wearing a shirt on this rare occasion, check out our YouTube where you can watch the episode.
Or Spotify. And for those of you that are hypermobile or interested in learning more about hypermobility, we are launching a hypermobility program in June of 2022. So whenever you're watching or listening to this, that will be coming out shortly. Thank you. Bye.